Good afternoon, everyone, and thank you for joining today's webinar, Clinical Insights, COVID-19 in the Liver Case Studies and Updates. My name is Elizabeth Verna, and I'm from Columbia University in New York, and I'm pleased to be moderating this webinar. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. As a reminder, you are encouraged to submit questions for the panel using the Q&A box at the top or bottom of your screen, and please not through the chat function. We will answer as many questions throughout the presentation through the Q&A function as time permits. And at the end of the presentation, some of these questions, as well as those submitted ahead of time, will be asked of our panelists after the speaker presentations are completed. We will not be taking any verbal questions during the webinar. As I mentioned, I'm Elizabeth Verna from Columbia University in New York, and I will be moderating this event. I'm honored to be joined by a distinguished panel of speakers, including Oren Fix, Ryan Kwok, and Mike Shilsky. We also have an experienced panel of leading hepatologists from around the country who will be taking your questions at the conclusion of our speaker presentations. And finally, I would like to acknowledge all of the members of the AASLD work group who have worked so hard to make these resources available in a very short period of time. After a few introductory remarks, our agenda for today includes an overview of updates to the Clinical Insights document from Oren Fix, a journal club highlighting important new treatment information from Brian Kwok, and then 3 case presentations from Dr. Shilsky. This will be followed by a question and answer session for our panelists. I will start with just a few remarks about the state of the US epidemic and some data on transplant recipients, specifically at our own center. COVID-19 continues to spread with new cases throughout the entire country. The total of confirmed cases is now up to over 600,000 in the United States. And this includes over 200,000 in New York State alone, where we have 8 counties in the New York City area with over 15,000 cases each. Perhaps a ray of hope out of New York and in terms of our national numbers is that the total number of new confirmed infections per day seems to have declined from a peak several days ago. Although here on the front lines, it appears we have not yet peaked in terms of our overall utilization of hospital resources. As our cases today focus on liver transplant candidates and recipients, and certainly these patients are just as affected by the epidemic as everybody else, I would like to briefly share some of our evolving information from New York Presbyterian, where we have a number of liver transplant recipients who have been tested positive. So as of the 15th of this month, we had over 150 solid organ transplant recipients with confirmed SARS-CoV-2 infection at New York Presbyterian. And we have had the opportunity to analyze 90 of these patients in greater detail. And while these outcomes are still being updated, I wanted to share some preliminary information about these patients to frame the cases you'll hear about later today. For the purposes of analysis, we categorize these patients by their disease severity, including those with mild disease, which we defined as being outpatients, moderate disease admitted to the general medical floor, and severe disease requiring mechanical ventilation, ICU admission, or died due to COVID-19. Here are some high-level information about the basic demographics of this cohort. This is again the first 90 patients, and 24% of them had a severe disease course. Similar to the other COVID-19 cohorts that have been reported, patients with severe disease were significantly older and were more likely to have hypertension and to have an active cancer that was being treated. Interestingly, thus far, the different organ groups had similar rates of severe disease, and the time from transplantation also did not differ between those with and without severe disease, even including patients within the first month following transplant. These are the treatments and outcomes available so far, and again, these numbers are being updated as some of these patients are still within their hospital course. However, at this time, this is what you're seeing here is just the hospitalized patients, so just those with moderate and severe disease, which is 72% of our overall cohort. The vast majority of patients had their antimetabolite decreased or held upon diagnosis with SARS-CoV-2 virus, while the steroid and calcineurin inhibitor dosing was less likely to be adjusted. Most patients received hydroxychloroquine, and 8 patients each received bolus steroids or tocilizumab specifically to treat the inflammatory response to the virus. 19 patients overall required ICU care and intubation so far, and 10 patients have died, which is 11% of our overall cohort, and 15% of those who are hospitalized, and 45% of patients that required an ICU. While these data are just preliminary, I think they highlight how much we still have to learn about how best to treat our transplant patients, and I hope the case studies we'll hear today will help us understand a little bit more about that. So with that as an introduction, without further ado, I would like to introduce our first speaker, Oren Fix from Swedish Medical Center, who will go over this week's updates to the COVID Clinical Insights document.
Thank you very much, Betsy. Welcome, everybody. Next slide, please. So for those of you who may be unfamiliar with the document online, we first published it March 23rd, and we posted an update a week ago, April 7th, and a new update's just been posted this morning. We also have Spanish and Portuguese translations available online, and a manuscript in hepatology has just been published online. Next slide. I'm going to go over some of the major changes since last week. In terms of chronic liver disease and the risk of COVID-19, are emerging data that suggests that patients with NAFLD may be at higher risk for COVID-19. We're not sure if that's the nature of the disease itself or whether it's the comorbidities that are both associated with severe COVID-19 and NAFLD, such as morbid obesity and diabetes. So since we aren't really sure about the data here, we're recommending that patients with chronic liver disease and also transplant recipients should be considered potentially at increased risk for severe COVID-19, and we're awaiting further data. And I think some of the data we're seeing from New York in particular is going to help inform us about these things. Next slide, please. As far as evaluating liver biochemistries, there was some confusion about our initial recommendation to test for hepatitis B and C in patients with COVID-19 and elevated liver tests. And that wasn't to necessarily single out B and C over other diseases that may also be in play, but just that hepatitis B and C was shown to be risk factors for severe disease in SARS, and we felt that this might also be true for COVID-19. But certainly in a patient with elevated liver tests, you need to consider etiologies other than COVID-19 in addition to hepatitis B and C, and that might include hepatitis A, et cetera. So we've updated the document as well as figure 1 to reflect that. Next slide, please. There's also been some confusion about our recommendations regarding treating hepatitis B and C, and so we wanted to clarify that. There really isn't a reason not to proceed with treatment of both hepatitis B or C in patients without COVID-19 if clinically indicated, but do keep in mind that there are logistics involved with this that may be difficult during this time, for example, getting lab draws and lab monitoring. In patients with COVID-19 and hepatitis B, treatment is not routinely warranted, but should be considered if there's a clinical suspicion of hepatitis B flare or if initiating immunosuppressive therapy. And finally, for hepatitis C in a patient with COVID-19, it's generally not warranted to start treatment right away, and this can usually wait a couple of months. Next slide, please. We also updated our section on liver transplant challenges based on some experience coming out of New York. When you're considering which patients to bring in for transplant, think about some of these things, like the risk of nosocomial transmission during the transplant admission itself, and that might impact who you decide to bring in and what is considered urgent. Also consider the difficulty in obtaining procedures or other resources if complications arise post-transplant. And also think about the limitations on family and caregiver visitation during a post-operative period that often relies on the engagement of caregivers. This might make it really difficult to educate the caregivers at the time of post-transplant discharge. It needs to be considered ahead of time. Next slide. For endoscopy, we've recommended canceling elective and non-urgent endoscopy, but consider in the interim primary prophylaxis with beta blocker therapy for those patients who have clinically significant portal hypertension or may be at high risk for decompensation. Next slide. And then finally, on masks, as more and more data becomes available that suggests that a surgical mask worn by infected individuals may reduce the risk of transmission, so-called source control, we recommend that all healthcare workers wear a surgical mask in patient care settings. And this is really in line with CDC recommendations and a lot of recommendations that are coming out at our individual hospitals and healthcare centers. Next slide. So with that, there are available resources from AASLD at our AASLD COVID-19 resources page, and the link is there. Our document is on that site, as well as the translations that I mentioned. Future updates are planned as new information becomes available, and our manuscript is now available on the Hepatology website under accepted articles. Thanks very much.
Thank you, Oren. And our next speaker is going to be Dr. Ryan Kovac, who's going to give us a rapid fire journal club focused on updates in treatments.
Thank you very much, Dr. Verna. Next slide, please. So just a little bit of background, as I think most of us here are aware of, there is no current proven effective therapies for the coronavirus. However, there have been several therapies that have been used in an off-label or compassionate use fashion. So today I'd like to review with you some of the recent data published on remdesivir, tocilizumab, and convalescent plasma. Just a couple definitions that I think are important to review. Both the severe and critical definitions are listed there, and those are put forward by the Chinese to help us define the severity of illness in these patients. And all patients that we'll review today fall under these categories. Next slide, please. So to begin with remdesivir, as many of us know, this is a prodrug of a nucleotide analog, which functions as a viral RNA polymerase inhibitor. It has shown activity against several virus families to include the coronaviruses and the filoviruses as listed there. It has been used recently in the use of treatment of the Ebola virus, and some safety data has been published with its use in that setting. Next slide. So that brings us to this paper that was published at the end of last week in the New England Journal that focuses on the compassionate use of remdesivir for patients with severe COVID-19. As was mentioned, this is a compassionate use protocol. Patients were started on a 10-day course with a dosing regimen as is listed. For inclusion, all patients were hospitalized with low oxygen saturations or requiring supplemental oxygen, creatinine clearance greater than 30 milliliters per minute, transaminases less than 5 times the upper limit of normal, and none of these patients were allowed to be on other investigational agents, and that'll make this distinct from the other papers that we'll review today. Next slide, please. So this is a slide which reflects their table 1, and I just pulled this to demonstrate to you some of the oxygen support that is required in the patients that they reviewed. So specifically, approximately 2/3 of the patients were on an invasive ventilatory strategy, with the balance being on non-invasive oxygen support. Overall, they enrolled 61 patients, 75% of which were male, with a median age of 64 years. And they spent about 12 days prior to giving the first dose of remdesivir from the onset of symptoms. These patients were then followed for 18 days after administration of the study drug. 53 patients were ultimately analyzed from the countries that you see there, with most being from the United States and Europe and Canada, and a small cohort from Japan. It is notable to see that approximately 25% of these patients did not receive the full 10-day course of the drug. Next slide, please. And so this is the primary chart which will focus on the results. So I'll point your attention to the x-axis, which is the oxygen support at baseline. So prior to the administration of the drug, with the red color representing those on the highest or invasive ventilatory strategy, and then those on the right on the ambient air. And then on your y-axis, you'll see the outcomes after administration of the drug as measured by the oxygen support. And so overall, this cohort experienced a 13% mortality rate, of which 18% were seen in the invasive ventilatory strategy, while just 5% in the non-invasive. Factors that were analyzed that demonstrated to exhibit risk of death were found to be the baseline serum creatinine, as well as a strong predilection for age greater than 70, which is represented by the Kaplan-Meier curve that you see on the lower right-hand corner. Next slide. This is a summary of the adverse events, and I'll point your attention to the lower left-hand corner, where you see that near a quarter of the patients experienced some serious adverse event. Overall, there was a 60% rate of any adverse event, of which 23% of the patients experienced some level of hepatic enzyme increase. It is notable to see that 4 patients overall discontinued the trial drug prematurely, and 2 of those were actually related to elevated aminotransferases. Next slide, please. This is the last chart that I'll show you from this study, and it is a by-patient review of their overall changes in oxygen support from their baseline after treating it. The dots that you'll see on the left side represent the overall outcome, with the blue dots representing an overall improvement in status. And so I think that this tells us that there's certainly promise for remdesivir in the treatment of coronavirus, but certainly the controlled trial and data are eagerly awaited and will inform a lot of how this drug may be used going forward. Next slide. So we'll change gears a little bit here and talk about COVID-19 and the cytokine storm, and a drug that may be used to intervene on this side of this. As many of us know, there's a proposed pathogenesis for the coronavirus that involves cytokine storm, with cytokines such as IL-6, TNF-alpha, and IL-12, among others, implicated. It's been demonstrated previously that IL-6 may be have a role in the alveolar capillary blood gas exchange dysfunction, thus leading to the impaired oxygen diffusion that we may be seeing in these patients. So you can imagine that that's a desirable target to focus on when trying to treat these patients. And so studies have been examining the use of tocilizumab, which is a recombinant humanized anti-IL-6 receptor monoclonal antibody. This drug actually already has an FDA indication in a variety of rheumatologic conditions, such as rheumatoid arthritis or giant cell arteritis, as well as a cytokine release syndrome, which has been seen associated with the use of CAR T-cell therapies. Next slide. And so in this study of 21 patients out of China, you'll see that this is the drug that was used. 86% of these patients were male with a median age of 57 years. And all the patients met the criteria for severe critical disease. I'll point your attention to the box in the lower left-hand corner, which demonstrates that only 10% of these patients were on an invasive ventilatory strategy when compared to the New England Journal paper, in which approximately 2/3 were. So overall, a little bit healthier of a cohort. These patients received treatment according to the local protocol, which did include the use of steroids as well as other antivirals. And the dosing regimen that you see is there. There was no data reported in this study on the time to dosing from onset of symptoms or admission to the hospital. And it should be noted that 3 patients did receive a second dose of this drug, and that was based on the clinical judgment of the investigators and was primarily given due to worsening clinical status. Next slide. So here are the results for this study. Overall, no adverse events were reported, and they did demonstrate that there was an improvement in overall laboratory parameters and the oxygen requirements, as you'll see by the graph on the lower left-hand corner. On the right side, you'll see that the overall improvement in laboratory status after the dosing of tocilizumab. I've highlighted for you the lymphocyte percentage, which was demonstrated to increase, and we know that the severity of disease has been associated with lymphopenia in the coronavirus. Overall, these patients were hospitalized for nearly 2 weeks after their dosing, and at the time of publication, 91% of them were discharged, with 10% remaining hospitalized, but overall improved. Next slide, please. So I did want to highlight some risks that are associated with this drug. As I mentioned, this already has had an FDA indication and approval, and so studies have been done to examine this drug's effect on the liver specifically. And so what I want to note here is that according to this pooled analysis of several hundred patients, there have been significant incidents of elevated liver enzymes in this series. Over 70% of these patients experienced some degree of ALT elevation, while nearly 3% experienced 5 times the upper limit of normal for that assay. And 2.5% ended up stopping the drug related to their hepatic injury. There were 7 severe hepatic adverse events that were reported in this series, to include 1 patient with acute liver failure, though it should be noted that this patient had significant comorbidities and were on other disease-modifying rheumatologic drugs. As I think many of us know, the monoclonal antibodies have been associated with a theoretical risk for hepatitis B reactivation. So us as hepatologists need to be aware and vigilant of that in the use of this drug for our patients with coronavirus. There has been a report of intestinal perforation in one patient associated with pneumatosis intestinalis, as well as reports of severe allergic reactions and even anaphylaxis. Next slide. So that brings us to our final study drug here, which is the convalescent plasma therapy. As some of us have seen, this is an adaptive immunotherapy that's been in use for more than a century and has been used with success in other coronaviruses such as the SARS, MERS, and the 2009 H1N1 influenza pandemic, and has been shown to be safe and efficacious. There has been a meta-analysis of 32 studies which examined its use in SARS and in severe influenza. And they demonstrated a near 75% reduction in mortality when compared to placebo or no therapy. Additionally, in the H1N1 pandemic of 2009, it was also demonstrated to show a significant reduction in viral load and cytokine burden, which has been associated with improved outcomes in the coronavirus. Next slide. And so for this, I'm going to review two studies and just give you the composite data. These are both small series that are using this with a total of 15 patients with either severe or critical COVID, of which 8 patients were mechanically ventilated, the majority of which were male with a median age of 52, but ranging from in the 30s to the 70s. And convalescent plasma was administered anywhere between 10 days and 22 days across this series. In this series, it should be noted that multiple other antivirals, immunosuppressives, and anti-inflammatory drugs were allowed to be used with these patients. Next slide. And so here are the results. Overall, of the 8 patients that were mechanically vented, 50% were able to be extubated by the time of publication. And they also did experience an improvement in all clinical parameters to include laboratories such as IL-6 levels, procalcitonin, CRP transaminases, and the lymphocyte counts also showed improvement. As you can see by the bottom right-hand corner, the appearance of the CT of the chests improved for all of their patients, highlighted with 2 of them there. And it is notable to see that all patients experienced a complete eradication of their viral load after administration of convalescent plasma. No safety or adverse events were reported in this series. Next slide. And so just to summarize our trials here, I think overall these data are very, very encouraging. However, there are some significant limitations which we should all take into consideration when we're considering these data. As I think we all know here, all these trials are observational. And so by definition, they lack randomization and any controls. And so that really does limit our conclusions about the efficacy and safety of these drugs. Furthermore, because of the design of some of these studies, the effects of these things may be confounded by the use of additional therapy, specifically seen in convalescent plasma in the tocilizumab trial. Overall, there was a relatively high percentage of patients on a non-invasive oxygenation status. And so it begs the question, would these patients have improved spontaneously, or is it in fact the effect of the drug? And finally, it may be considered that there was a relative delay in administration of the treatments with a median of approximately 6 days across all studies. And that may be offer a bias towards overall healthy patients. And again, asking the question if they may have improved on their own. And so you can imagine that I think we're all eagerly awaiting the data from the controlled trials. Next study, next slide. This is just to give us an idea about the trials that are ongoing and just really to try and impress upon you that much study is being done, as we can all imagine, with nearly 400 trials ongoing as of last week. Next slide. And finally, just a chart that's showing us where the focus of our efforts are, with the majority of these trials being conducted in overall treatments, but a significant portion in vaccines, which I think we all know are going to be very, very important as we focus on moving forward and managing this disease. Next slide. I would point the audience's attention to the very nice publication that was put out last week by the IDSA in terms of the treatment and management, and it does do some really nice comparison of the data of the drugs that we talked about today as well as several other regimens that are more widely being used across the management of this disease. Next slide. And last, I'd just like to thank again the working group for the opportunity to present to you this journal club. As well, I'd like to just recognize my colleagues that are in uniform and those that are out there just putting themselves in harm's way. Last, I'd just like to acknowledge and thank my colleagues and mentors at the Uniformed Services University. Thank you very much.
Thank you, Ryan, for that excellent overview. And next we have Mike Shilsky from Yale New Haven Hospital, who's going to take us through some important clinical cases.
Thank you, Betsy and Ryan, for setting the stage for today. Next slide, please. I'm going to share with you 3 selected cases. The first is a homegrown one from our group at Yale. The next was submitted by one of our audience, and the third is from one of our panelists. So the first patient was a 60-year-old who was transplanted for cryptogenic cirrhosis and had hepatocellular carcinoma, and had an early post-transplant course that was complicated by C. difficile colitis, for which the discharge was delayed until day 17. On the day of discharge, the patient was asymptomatic and underwent a nasopharyngeal swab for the SARS-CoV-2 due to a potential in-hospital exposure, which was estimated to occur about 4 to 5 days prior to the discharge. At time of discharge, the immune suppression was tacrolimus and prednisone, and the patient received standard prophylaxis with fluconazole, valganciclovir, and trimethoprim sulfamethoxazole. And the next day, it turned out that the PCR test became positive for the SARS-CoV-2. The patient reported no new symptoms, and we counseled her family and educated about precautions, and at that time she remained at home. Laboratory testing was arranged at her home on the following day, on postoperative day 19, and at that time there was no elevation in transaminases. The white blood cell count was 5. The tacrolimus level was at target at 8.6. And the CRP and the ferritin were beginning to show elevations of 86 and 694 respectively. Next slide, please. So over the next 48 hours, the patient started to become symptomatic, first developing a low-grade fever and dyspnea, and was readmitted to the hospital. At that time, the chest X-ray was without any infiltrate, and the oxygenation was 97% on room air. And the CRP and ferritin continued to rise. I'll show you that in a moment. D-dimer showed mild elevation, but the troponins were normal. A couple of days later, the patient started to develop a reduced oxygen saturation, went from 95 to 87% on room air, was begun on nasal cannula, and responded well. At that time, the chest X-ray began to show new infiltrates. I'll show you that in a moment. Per our protocol devised by our infectious disease specialist, the patient at that time, when she went from mild to moderate disease, received a single infusion of tocilizumab as anti-IL-6 therapy, along with oral hydroxychloroquine, loading, and then daily dose 400 for 5 more days. During that time, the electrocardiogram was monitored for QTc interval changes. At that time, the prophylaxis with trimethoprim as well as fluconazole was stopped. Throughout her course, the prednisone was maintained at 10 milligrams, and tacrolimus levels were monitored and kept between 6 and 8. Oxygen supplementation was continued for 5 more days. It had increased slightly over the next couple of days, then went back down, and at 5 days it was no longer needed. The liver test did show some mild changes. I'll show you that on the next slide, but really remained mostly stable throughout. Next slide, please. This slide shows the correlation between the temperature, CRP, and the ferritin during her clinical course. During the first few days when she was becoming symptomatic, the temperature had raised, and at that time you see the elevation in the CRP. The ferritin lag behind that was beginning to get elevated though. And as the clinical course improved in the patient, you see the decline in the CRP while there was a lag in the ferritin. The arrows show the timing of the intervention with the anti-IL-6 and the hydroxychloroquine. On the right, you see the X-ray that became abnormal at the time the patient was symptomatic and decreased her oxygenation. Next slide, please. When she was asymptomatic and recovering in the hospital, and afterwards, unfortunately, the discharge was delayed due to concerns at home because her repeat nasal swabs were continued positive and were even at 16 days into her admission, and that was about 20 days after the exposure. A few days later, about the 526 days after the exposure, she had an equivocal PCR, and we were getting very excited she was possibly clearing, but just the other day it turned back positive again. So we think that she is a prolonged viral shedder due to the immune suppression. On the right, you'll see her liver tests, and you can see at the time she became symptomatic, the tests really were not remarkably elevated, minimal changes in the AST, and the alkaline phosphatase became more elevated later, actually after the hydroxychloroquine, so we don't know whether that was part and parcel of the disease or the treatment in her. Next slide, please. So discussion points for this patient. There are some important features, so that even if the testing is negative in a donor and recipient, we have to remember there is a risk for post-transplant exposure at this time, is that because there are asymptomatic individuals within our healthcare system that potentially come into contact with our patients. When they become actively infected, fever and dyspnea are very common features, and these are paralleled by changes in the inflammatory marker CRP, showing a very good parallel to the fever curve and the oxygenation. The immune suppression in these patients need not be lowered, and especially in mild and moderate COVID disease. Betsy had presented some data on some of the patients with more severe disease where perhaps it was changed more aggressively. Therapy with the anti-IL-6 and hydroxychloroquine in this patient was initiated when there was a change from mild to moderate disease. And hypothetically, this may be better than waiting for the severe disease to occur because the cytokine changes are beginning in those individuals. The other point to make is that liver tests were really minimally elevated despite the viremia and the therapy in this patient. And we know that viral shedding is prolonged with immune suppression. And so that may create management problems in some of these patients. Next slide, please. The second case was submitted by our audience, and it posed to us a 16-year-old male with acute liver failure due to hepatitis A. The patient had antibody IgM to the SARS-CoV-2 and had a positive PCR for the nasopharyngeal swab for the virus as well. And the dilemma postulated to us was whether to transplant or not to transplant. Next slide, please. In considering an answer to this question, it really points to the pillars of ethics in our decision-making processes, and really have to consider the three pillars of non-maleficence, beneficence, and justice. For non-maleficence, we certainly want to know if we're going to proceed forward that we're not going to perform a futile transplant, that the patient has a chance of recovery. With respect to beneficence, we certainly know that the acute liver failure itself is a death sentence, and therefore we have the opportunity to do good, but again, only if we have an opportunity to know that we can have a positive outcome. And with respect to justice, we have to consider the principle of distributive justice, and that we have to make best use of this rare resource, which is our organ supply. And we want to know that we are not going to perform a futile transplant in this individual, and therefore we would then be doing poorly by our community at large if we were to do that and without the hope of a good outcome. What we have learned from limited data from our colleagues in Europe and around the US suggests that survival of patients with acute acquisition of COVID disease at the time of liver transplant or perioperatively is survivable. However, we do know some deaths have occurred, and we really don't know the full statistics of this at this time, and we certainly will learn more as time goes on. So considerations for the decision process include that we have to really think about the condition of the recipient at the time of the organ offer. So in making an assumption that the patient has good oxygenation, no ARDS or multi-organ failure, and combine that with young age, lack of other comorbid conditions that would give us poor outcomes with COVID disease, as well as considering this is a 16-year-old with a potential longevity after receiving the graft, so we have to take into account potential years of benefit, would, in my opinion, favor proceeding with the transplant. However, I think if any of these variables were different, for instance, if we didn't have good oxygenation, if we already were in the stage of multi-organ failure, or if the individual had older age or if had many of the other comorbid features which would potentially lead to a poor outcome with COVID disease, I think our decision might be different. Next slide, please. And for our third case, we thank one of our panelists, Dr. Jamie Chu from the Mount Sinai Medical Center in New York, who contributed this case of a 10-month-old girl with a history of biliary atresia and a failed Kasai enterostomy who is actively listed for transplant. This patient had a complaint of nasal congestion and increased work of breathing that was noted, and a telemedicine visit was performed. And at that time, there was a history of mild subcostal retractions. And otherwise, the patient was afebrile, did not have a cough, and had a good disposition, was able to eat and maintain hydration. On the following day, the patient was seen again and was noted to have this time worsening tachypnea, had signs of labored breathing, and was sent to the emergency room. The past history included the portoenterostomy performed at day 46 of life with failed biliary drainage with consequences of worsening liver disease with ascites and jaundice, and the patient was on diuretics at home. The patient did not have a history of bacterial peritonitis or of variceal bleeding. Now, importantly, the social history was that even though there was no contacts at home, the family lived in a populous area in East Harlem, and with the mother and 3 sisters, and the mom was outside the home working in a store. And even though it took protective measures, we are uncertain whether there was a contact within the family. The older sister had 1 episode of emesis, and other family members were reported to be asymptomatic. Next slide, please. When the patient was seen in the emergency room, there was mild tachycardia, temperature was not elevated, there was tachypnea, and oxygenation was good at that time. Patient was non-toxic, jaundice, did have labored breathing, did have ascites and hepatosplenomegaly. The white blood cell count was not particularly elevated. However, there was an unusual predominance of atypical lymphocytes not normally seen. The hemoglobin was 10, creatinine was normal, INR was 1, D-dimer was not, was minimally elevated. Transaminases, which are abnormal to begin with in this individual, were minimally changed, as was the bilirubin in this previously jaundiced patient. CRP wasn't as particularly elevated, and procalcitonin was within the normal range. Next slide. The X-ray, however, on admission did show changes which were consistent with the viral process. A respiratory panel for other respiratory viruses was negative, and the swabbing nasopharyngally was negative for SARS-CoV-2, and it was even repeated 24 hours later and still was negative. The patient did show worsening and was admitted to the pediatric ICU, required high flow nasal cannula oxygenation. And with the history of end-stage liver disease and being in a highly endemic area, and given the clinical presentation and chest x-ray findings, she was still treated as presumed COVID positive. She was started on antibiotic for possible secondary pneumonia and was treated with protocol hydroxychloroquine and azithromycin. She was in the hospital and initially had responded and was requiring less oxygenation, however, did have a resurgence of symptoms several days later, and at that time the x-ray and the liver test did remain stable. Next slide, please. So from this case, we learn certainly it's important that by history alone, it's not always clear who the contagious contact may be, as asymptomatic individuals may be there, or indeed maybe it was the sibling who had the minor GI symptom that could have been the household contact for COVID. The current diagnostic testing by PCR has limitations, and certainly here with 2 negative tests and the right clinical scenario in the endemic area, I agree with our panelists that this certainly was a positive case. It's important that in these individuals that get symptomatic, especially with underlying disease, early admission can lead to timely recognition of disease worsening and appropriate supportive care that may save the life of these patients. Now, continued monitoring is important, but counseling about potential recurrent symptoms, especially after somebody is better, it's important to warn them there may be a period where things could get worse, and also attention to the possibility of secondary infections as well is important. And treatments can be tried in these patients even with advanced liver disease. However, one has to be careful in that and monitor for worsening of potential liver function during this time. Okay, thank you very much.
Okay, thank you. Thank you for these really insightful cases. And we'd now like to turn this over to a discussion with our panelists. Thank you everybody for submitting the questions that you have, a lot of really excellent questions, and I hope we're able to get to a lot of them today. So the first question I'd like to pose to Dr. Brown from the Henry Ford Health System in Detroit. Dr. Brown, how are you managing your transplant wait list there? Should high-MELD patients be screened for symptoms or tested weekly to make sure that they're ready to go if they get a good offer? And how are you determining whether to proceed with a transplant sort of based on risk stratifying the particular candidate?
Thanks, Betsy. Those are great questions. We've taken the strategy of trying to prioritize patients based on their risk of mortality, and we use MELD for that. Thinking toward the patients that would be the highest risk, more moderate risk, and less risk, and deciding on intervals of testing as well as, and we are doing video visits with those individuals while listed. The testing for our highest MELD patients has been weekly. The issue, though, with that is that because viral shedding may occur in asymptomatic patients, all patients would, through the protocol, be retested upon admission. And the issue with that I would point out would be some of the data from the New England Journal article out of New York that looked at women who presented in a birthing room when giving birth that were screened with the findings that actually over 13% of those women upon presentation for delivery were actually positive for COVID but asymptomatic. So I think it behooves us that if we are testing in the outpatient setting, which I think we should certainly do it when patients present. The bigger question is how we're managing those patients at the time of presentation or offers. And this is really much more complex and requires that we think through a safe pathway for these individuals after transplantation. At the present time, given the number of COVID patients in our hospital and our inability to provide a safe pathway for a patient with a high MELD, we've actually during this period transferred 2 of our patients to other centers for transplantation to provide a safe pathway. So I think it will vary center to center and depending on the prevalence of COVID in your area.
Great, thank you. And actually for that reason, I'd like to ask pretty much the same question of Brendan McGuire at UAB. It's in a different area of the country and possibly with a different local prevalence. So how are you guys managing your wait list there in terms of the risks and benefits of proceeding with particular transplants?
Fortunately, we do not have all the issues that Kim just spoke about. In the state of Alabama, we have under 4,500 patients who have acquired COVID-19. Fortunately, this has not strained our hospital with over 1,100 beds. Unfortunately, as we are all aware though, approximately 20% patients listed for a liver transplant will die waiting for a liver transplant throughout the United States. Thus, I think for these patients on the waiting list for a transplant, I believe they have a better chance of dying from their liver disease than acquiring and dying from COVID-19. Thus, we're still performing transplants in our state, and we're following the guidelines from CMS in which transplants is designated as a Tier 3B.
Okay, great, thank you. My next question is for Laura Kulik at Northwestern. We got a bunch of different questions about the second case that Dr. Shilsky presented, where we're posing the possibility of taking a patient we know to be COVID positive to the OR for a transplant. So do you have anything in place at Northwestern with your team about how you approach the perioperative period in these patients? Are you screening everybody who comes in for a transplant? And is there a plan in place for you guys if someone actually tests positive? Laura, we can't hear you.
Can you hear me now?
Yep.
Okay. So we are, when patients are called in for transplant, they're being met at the door and being masked and brought up, and a COVID test is done. Our anesthesiologists have put in a protocol that they will not take anyone to the operating room without knowing the results of their COVID test. Now, having said that, I've spoken with our head anesthesiologist and asked if they would proceed if positive, and his answer was if it is life-threatening, yes, they will proceed. They are doing measures such as using a glide scope to distance themselves from the patient. They are having the senior anesthesiologist be the one who intubates in the room alone, and to try to decrease the risk of exposure to others during the time of intubation.
Okay, thank you. Our next question is for Oren. So I wanted to ask you both about what strategies your team is using to adjust the immunosuppression of patients who come into the hospital post-transplant with COVID infection. And also we had a great question posed through the Q&A here asking about how, you know, it seems like some areas of the country are still getting overrun with infections while there are others where it seems like people are interested in trying to go slowly back to business as usual. So are there any ramp up efforts going on in your hospital or any plans in place to do that soon?
So 2 good questions. I think we've been really fortunate in Seattle. We haven't seen the surge that we anticipated. We're certainly nowhere near where New York is right now, and we think we're past the peak. So we are starting to think about you know, business as usual and how do we start to get back to normal, but also recognizing that we can't do that too quickly or we're likely to start to cause more spread of the virus in our community. So for your first question, generally speaking, you know, we're not making changes prophylactically to immunosuppression. We have not had a patient, post-liver patient with COVID. We have had some post-kidney transplant patients with COVID. But if we were to have a patient post-liver transplant with COVID and they're not significantly ill, we might consider reducing or stopping the antimetabolite and really leaving everything else as is. and then just wait and see. If they become critically ill, certainly we have to think about reducing other immunosuppression. But we also have to consider that there have been some data coming out of Italy showing that post-transplant patients in some cases are doing quite well and potentially protected by the fact that they're immunosuppressed. And there are other patients post-transplant who are doing very poorly, and we don't know if that's related to immunosuppression or whether it's because of comorbid conditions such as obesity, diabetes, and things like that. For the question about getting back to normal, we've really not changed our approach to transplant. We were going to take every transplant recipient with a donor offer on a case-by-case basis and determine if we felt this was someone that could potentially wait a couple of months versus proceeding, sort of what Brendan was saying, that we don't want to postpone life-saving transplant in a patient that may not survive this pandemic and then make the pandemic actually worse. We also stopped really seeing patients in person in clinic, and we're gonna have to start thinking about how we start seeing patients again in person, which patients we're willing to see, and I think we're gonna have to start prioritizing new transplant evaluations, and we probably look at the MELD score as a way to triage those patients. I think of all the patients that we usually see in clinic, I think it's very difficult to do transplant evaluations on video. I think that the interactions between the patient and their caregivers is really important. And there are other factors such as patient education and meeting with multiple members of the transplant team, where I think doing it in person is really preferred. And those are the first patients we're going to start to see, I think, in person as we get back to normal.
Okay, great. The next question I have is for Patricia Heron, who's a DMP that's at our program here at Columbia, and I think has a unique perspective here in New York as both running our transplant center and all of our clinical operations on the outpatient side, but also has been deployed and is coming off a night shift actually last night, taking care of a COVID service in the hospital. And Patricia, I wanted to ask you how deployments and changes in staffing are impacting sort of our overall patient care in terms of our transplant center and the staff morale, and how you're managing changes in the operations in the comprehensive transplant clinic in order to adjust to the current pandemic.
Thanks, Betsy. For the staffing, the staff being deployed, we have all disciplines deployed: surgery, hepatology, our advanced practice nurses, RNs, MAs, our admin support are working as transporters. So it's been really challenging to run daily operations. Early days, staff was either out on quarantine or COVID positive themselves. This started a large amount of anxiety and tension throughout the program. Once deployment started, we rapidly went from 12 advanced practice nurses to 2.5 full-time staff to manage a large post-transplant group of over 1,600 patients and several hundred pre-transplant. All staff started to work remotely. We ramped down operations until even our front desk, who answer the phones, now work remotely from their home. Only urgent patients are seen in one half-day session a week by a hepatologist, and those patients are screened for urgency. All visits are otherwise done by telemedicine. Since the volume of lab reviews have diminished due to quarantine patients themselves, all the advanced practice nurses, although deployed, check all their own labs. And then the staffers who are not deployed handle all the phone call, any paperwork, visiting nurse, patient callbacks, setting up admissions, etc. And the teamwork and dedication of all the staff has definitely increased morale. One of our biggest challenges we have is the comprehensive transplant clinic. We have a clinic shared by lung, renal, and liver. And early days, we likely did not reduce patient volume fast enough. And although we have 2 layers of screening many patients before they enter the clinic, patients did not answer affirmative to the screening questions and were found to be COVID positive. They were picked up when the MAs were doing temperatures, and patients didn't even realize they were running low-grade temperatures. And then when swabbed, ended up being positive. This resulted in many of our staff being exposed and then being put on quarantine and becoming positive themselves. The lung transplant program shut down very early and converted 100% to video visits. Several of their staff, over 6 of their waitlist coordinators, became COVID positive. The liver program reduced rapidly to 1 half-day session, as I mentioned before, for urgent visits and consults. And the renal program is still seeing 1 to 7 patients daily, but many of those are visits in conjunction with infusions of immunosuppressive related to studies that they're, or just regular immunosuppression that they get every 2 weeks. The clinic is now only open 4 days a week for 5 hours a day, and infusion is running 7 hours a day. Patients, if the clinic volume of patients scheduled is under 5, patients are auto-arrived, and we don't bring in our check-in staff, and we staff it with 1 MA who will do vital signs and specimen collection. We're looking towards how we're going to reopen this clinic and how we're going to staff it. And so unfortunately, we've had many of our staff become COVID positive because of early challenges, but they have all recovered very nicely, and those will be the people who will come back in and staff the clinic when we start to reopen. We are now currently just starting next week doing a 1-day only patient visits for patients we know are COVID positive. And we'll do only infusions of COVID positive patients on that day. Since there's no data on how long immunosuppressed patients shed virus, we're swabbing all the patients at every visit to see when they convert. And we are requiring that they go to a COVID clinic day until they have 2 negative screens. The programs are now, as of today, instructed to convert all office visits to video visits for the month of May. The hospital is not opening outpatient routine visits until likely very late May, early June.
Wow, thank you, Patricia. It's a lot of really important information that I think, hopefully will be helpful as other programs need to gear up for this. So I wanted to also ask Jamie Chu, who's a pediatric hepatologist from Mount Sinai and provided that great case for us. I think we know that the COVID-19 pandemic seems to have been a little bit less impactful in the pediatric population overall, although certainly we're all seeing kids admitted to the hospital with this syndrome. I wondered if you could share a little bit more about the burden of disease you're seeing in the pediatric population in terms of transplant candidates and recipients, and also whether there's any different strategies in terms of antiviral medications or immunomodulatory agents that in particular are different for kids.
Thank you, Betsy. As you mentioned, children seem to be less symptomatic from COVID-2 infection, and that has been our pediatric liver experience at Mount Sinai as well, even in our children who live in densely populated endemic areas. In terms of our pediatric population, the prevalence of COVID-19 is largely unknown because our approach has been to avoid having our pediatric patients, especially those post-transplant, come into the city or into the hospital whenever possible, which means they end up going untested unless they have moderate to severe symptoms that warrant evaluation in the ED. For those patients that have had fevers at home, the majority do have mild respiratory symptoms that haven't required hospitalization. We've had post-transplant patients who have had a parent with COVID disease, and we counsel the parent to self-isolate from the rest of the family as much as possible. So in all, our pediatric liver patients have fared reasonably well with these approaches. In terms of special considerations for antimicrobials or immunomodulatory medications, one risk that we do weigh in our pediatric population is the potential for combined effects on QTc prolongation in children with cirrhotic cardiomyopathy, especially those with biliary atresia, and when treating with hydroxychloroquine. And so to this end, we check EKGs to monitor QTc both prior to and during therapy.
Okay, great. Our next question is for Dr. Chung from MGH. We had a series of questions about really our evolving understanding of how the virus is impacting the liver. Are you able to comment on whether we have any updates in our understanding of the roles of the direct viral uptake versus immune-mediated effects? And in particular, we also had a question about biopsy findings, and I wonder whether you are aware of any updates about what we're seeing in liver biopsies, perhaps at least in some of the autopsy specimens.
Yeah, thank you, Betsy. Well, so our understanding thus far is that the receptor ACE2 is found most predominantly in the liver and in cholangiocytes, considerably more so than at least has been identified in hepatocytes. And indeed, there have been some recent organoid studies from China, actually, that have demonstrated uptake of SARS-CoV-2 into bile duct organoids, with replication demonstrated at least transiently in those organoid cultures. There was evidence in those cultures of injury to those cells, and specifically alterations in expression of bile transport proteins. And the potential for injury reflected in cholestasis. However, what we don't see to a prominent extent in these patients is really necessarily a cholestatic pattern. It is really predominantly, as you pointed out in a previous webinar, a transaminase predominant pattern. And specifically, that pattern is really AST predominant. And we have that experience in our own patient population. We've profiled the first 60 patients who were hospitalized with COVID, and have found that there's a consistent AST predominant pattern of injury. And when one looks specifically to try to tether that AST to potentially other sources, including muscle, or for that matter, cardiac muscle, skeletal muscle, hemolysis, we really don't see a tremendous correlation with those, at least in terms of a linear pattern of correlation of those AST elevations. Nor necessarily do we see a pattern of AST elevation that is closely tethered necessarily to inflammatory markers. In fact, the best correlation of AST is really with ALT, and that supports potentially then that there may very well be viral injury and infection to hepatocytes themselves. And you mentioned histology, and it's interesting to note that the histologic studies thus far have shown some heterogeneity, but one pattern that is seen is one of microvesicular steatosis, small vesicle fat, that suggests potentially a picture of mitochondrial injury. And it is interesting to see these AST to ALT elevations, given the known source of AST being both mitochondrial and cytoplasmic, that this predominance might suggest, or at least it leaves open the question of potential mitochondrial injury being mediated by the virus itself. So these are all, of course, hypotheses that are generated by the clinical information, and we certainly need to do additional experimental studies to verify these. But it does suggest that there may very well be at least some level of viral infection of the liver itself.
Great. I think you're right that we still have a lot to learn about that, but I would agree with you that that seems to be the pattern that we're seeing. Ray, I wondered if you'd also help me answer one more question that came up a number of times in the Q&A here, which is really whether we think hydroxychloroquine is working or not in these patients. And I'll tell you here at Columbia, this is a question we ask ourselves a lot. Most hospitalized patients here have been receiving it. In particular, almost all the transplant recipients have. And because everybody's receiving it, it's very challenging to understand, obviously, what the impact of that is on their overall outcomes. Because here, at least, we've not been randomizing patients to not receiving it. I'll tell you, in the transplant recipients, we've certainly had a number of patients who came in with sort of moderate oxygen requirements who were started on hydroxychloroquine and still progressed to clinically severe disease. But again, it's really hard to know if on the margin we made a big difference there. here we're not actually doing serial swabs to try to understand whether there's a difference in terms of actually viral shedding in any capacity, like a lot of the early studies. But obviously it's going to be a challenge to understand whether this is helping or not without having a group that didn't get treated. And I wondered what you guys are doing in Boston and if you have any other insights about whether we're going to know whether this drug is helpful.
Well, I think these are all extraordinary observations with regard to the dilemma that we face, which is the empiric use of something that there may be buzz about or a potential signal for, leading to sort of asymmetric practices that don't allow us to actually abstract truth from mere speculation. And so I think hydroxychloroquine is squarely in that territory. We are, there is still, I think, a fair amount of empiric hydroxychloroquine use taking place at our institution as well, but we are participating in a randomized trial, and that will hopefully be a study that helps us address this question more robustly. And in order to conduct that trial, we're going to have to really dial down and suspend the empiric practice of hydroxychloroquine administration. And I think it's something that we are prepared to do institutionally, since we really don't have an answer to the question. There is some evidence that based on that Brazilian study that hydroxychloroquine use, particularly with azithromycin, may actually do harm with regard to potential prolongation of QT and cardiac events. So I do think the randomized controlled trial is desperately needed, I think, for just that agent and to dissuade us from I think empiric use without a definitive answer.
Yeah, I couldn't agree more. I think it's really, really important. So I'm going to close maybe with one more question for Dr. Brown, which is, I think all of us are wondering about this, and I know Oren addressed this and some of the other speakers have as well, but I guess what are your thoughts on what it will take to start to get back to more business as usual and to feel more confident that the clinics and also the transplant program can start to open back up again and accept more patients?
Yeah, thanks, Betsy. I know we're all thinking about that. I think it will be different from center to center. I think what we have to focus on is understanding the way that we can provide a safe pathway for those transplant patients who are not infected to get through our hospital and remain uninfected. For us and for New York and for other areas that have a high degree of COVID in their hospitals and in their staff, we will run parallel operations for a period of time where we will have to try to the best of our ability segregate COVID from non-COVID patients, both in the OR, in the post-op areas, on the floors, and in our staff, as well as potentially in our clinics. All the lessons that we've learned in terms of asymptomatic spread of this disease remain the same. And I think as we start to open up and others open up, we have to keep this in mind. The other thing that I would say is don't assume everyone's going to come back. Now, our transplant patients probably will because they remain listed, but I was giving the example before of our surgery centers that are now opening up, and we've opened up 5 ORs in our entire system, and of the 50 patients that could have been scheduled, about 25 of them declined, and these were very time-sensitive, high-risk cancer cases. So patients are actually making decisions about this as well.
Yeah, I think that's an excellent point, that we have a lot of work to do to make sure that we can convince ourselves and also our patients that it's safe to come back, for sure. Well, I think I would like to conclude our webinar for today. I want to thank very much all of our speakers and panelists and all of the participants who really entered great questions for us to think about. And good luck, everybody. Be safe out there, and thank you for attending this webinar.